The show this week is the Vice President of Population Health at Henry Ford Jackson Hospital, Dr. Courtland Keteyian. Welcome back to the show.
Thank you.
And we appreciate all the many years of providing COVID information for us.
It is many years at this point. Yeah, it's many years. Yeah.
So COVID now, is it just now one of those things that we're just going to have forever?
I think so. I don't see it going away. It's very, for months. The better part of this year, honestly, it's been very steady in terms of the volume of cases we've seen in the community and what we see in the hospital. Probably since June, we've had 20 to 30 people hospitalized. There's at any given time. Yeah, at any given time, there's 20 to 30 people in the hospital with COVID. A handful of those end up in the ICU.
How many?
And a handful. 1, 2, 3 of those people end up in the ICU. And that's just how it's been. And the deaths actually continue. We've had in Jackson County, somebody probably once a week, maybe twice a week, somebody dies from COVID. If you actually look at the numbers per year, there was about 400,000 or 500,000 people that died each year between 2020 and 2021. We're on track this year for about 250,000. This is nationally. So COVID at that pace is the third leading cause of death in the United States.
No kidding.
Yeah. So behind heart disease and cancer. So that is to reshape the top 10 causes of death in the country is pretty incredible. And so I think if nothing else significant changes, it's probably going to be sort of slotted in there for the foreseeable future. It causes significant mortality and morbidity. Obviously, there's people that have these sort of long-term sequelae of when they get COVID, they get long COVID. It's created a pretty tremendous strain on society.
So if we had been better as a society in getting vaccinated, this could have been the end of the disease, the end of the virus, if we had a certain level of vaccination.
Yeah, I think that'll be something that experts look back on and analyze. It's hard because this is such a global disease that if you can't get the whole world there, there's always going to be disease that spreads, right? But I think the thing that we know for sure is that the more people that we were and have been able to vaccinate, the less mortality there is, the less people die, and collectively, right? If there's higher levels of immunity in the community, right, in folks that are here, whether that's in the county or in our country, there's less spread that happens, and then it's less likely to affect the people that are really susceptible. So I don't think there's any question that higher vaccine levels save people's lives. And
that's still the message, it's get vaccinated.
Yeah, I think that's the most important thing people can do. And I know there's been controversy over the vaccines since the very beginning, but they continue to demonstrate that they're incredibly effective, they're very safe. Really across the board now, sort of all of those studies. So at 6 months and over, there are vaccines available now for everybody. There are mRNA options, the Moderna, the Pfizer, also Novavax, which is a protein subunit vaccine. So that's kind of old technology like we've used in tetanus shots, for instance. So there's not just one type of vaccine available now. There's several sort of well-tested, very safe, and it's basically a primary series and a booster. And the booster is the bivalent, which gives you the protection against the newer strains that are out there. But I think it's probably pretty realistic to assume that most people really should at this point have their primary series, those 2 doses, either 3 or 4 weeks apart, depending on the brand, and then a booster that comes 8 weeks later. And then it's probably going to be something that we do at least on an annual basis, or want to do on an annual basis, like we do with the flu shot, just to protect people.
Well, do you foresee it getting reformulated each year to reflect the changes in the...
Yeah, I absolutely. Yeah, absolutely. I mean, just like we do with the flu shot, where the flu shot is, they really try to predict based on how activity is in other parts of the world, right? We kind of flip with the northern and southern hemisphere, right? Where it's winter down there, that's their flu season, and it kind of is opposite of ours. But yeah, I think that'll happen with COVID too, and we'll always be looking for the new strains and then trying to adapt what the vaccine is to make sure it's the most effective.
And I know that you heard people say, well, it's such a new vaccine, I want to wait a while and make sure it's safe, make sure no one passes away from this. But we're past that now. I mean, we've had this in our lives for long enough where if there was going to be something adverse, we would know about it.
Yeah,
right?
I think the data now on the vaccines it's excellent. I think it's very, very good. And we even, I mean, just to kind of give, because I have those conversations with people like everyone else, I'm not sure, and I'm concerned about the risk of the vaccine, et cetera. And, when we did, this is early on, the Henry Ford system provided oversight for the mass vaccine clinic at Ford Field. We vaccinated like 500,000 people there. Here in Jackson County, I mean, we vaccinated, I think, over 100,000. I mean, it was huge numbers of people we vaccinated. And there was a group of us physicians that would review adverse events, right, and make sure that any adverse events are being reported, and we track those things, because the CDC wants to know if there's adverse events. And so there's things we expected. I mean, people have allergic reactions. But we just don't see, we're not seeing the things people really, I'm not even sure what the word is to use, right? Conspiracy or whatever, some of the really crazy stuff that people have wondered about. I've seen that data personally, right? It's not filtered through studies or other people, and there just isn't anything there. I mean, they're just very safe.
No medical reason to not give it.
No, the science would say that the risk, I mean, given how prevalent COVID is, your risk of a bad outcome from COVID is significantly greater than your risk of a bad outcome from, a vaccine.
And a bad outcome is being hospitalized, being in the ICU, or dying.
Or dying, yeah, absolutely, yeah, and it's the third leading cause of death in the United States, right? So even if you just took away the fact that vaccines or anything else, and just looked at, what are the leading causes of death in the United States, and what are the top 3 things that will kill me? Well, I mean, I can protect myself from heart disease-related outcomes by my diet and my exercise, right? I can do appropriate screenings to try and avoid dying from cancer. I can get my colonoscopy, and I can get my mammogram if I'm a woman, my cervical cancer screening done if I'm a woman, and do those things to help, screen for those diseases. And to prevent myself from dying from COVID, I can get vaccinated, right? I mean, those are the things that you do, and those are the ways you prevent those leading causes of death. So it's very much in our control, right? Individuals have the control to prevent the really bad outcomes now.
Now, the age of people that are dying, there have been all kinds of reports throughout the course of the pandemic as to the age group, the population most vulnerable to death from COVID. Is it, as it's been reported so many places, older people that are more likely to die from COVID?
Yeah, absolutely, yeah. And then that's always been the case. I mean, the risk of death increases by orders of magnitude, right? I mean, like 10%, 100%, 200%, more likely to die as age goes up. So people that are 80 plus are very, very at very high risk. And it kind of steps down as people get younger. But yeah, there's a really clear correlation with age. And I think I saw a statistic that right now, 9 out of 10 COVID deaths are people that are over 65. So it's predominantly settled now, sort of in that category. And there's a variety of reasons for why that's probably the case. But even if those folks are getting immunized, like they may not be able to generate as robust of an immune response. And there's obviously much higher burden of chronic disease in those populations, which is why actually it's really important if somebody. So this is what I think people are struggling with now is they'll get something, a little upper respiratory something, right, and say, it's just a cold, right? You really need to know what it is. And actually, the most common symptom now of COVID is sore throat. There was a study that was done in the UK where they looked at that, and so congestion, little fever, sore throat, anything up here, you really should get tested to know exactly what it is. And so obviously if it's COVID, there's other things circulating too, but to know if it's COVID. And the reason is there are medications that help prevent the really bad outcomes. So the Pfizer medication, the Paxlovid, is excellent at preventing the really severe outcomes. It must be taken within the first 5 days to be effective. And a ton of people really are eligible to get that. So things that increase risk of a bad outcome are being overweight. So a BMI technically over 25, which is overweight, which is like 70% of America. Any heart problems, high blood pressure, lung problems, asthma, COPD, immunocompromising conditions. People take medications for rheumatologic diseases, maybe they take steroids. It's a really, really kind of broad list of conditions that could compromise somebody's immune system, put them at higher risk. And those folks really should have a conversation with their doctor about whether they should be getting Paxlovid to prevent those really severe outcomes. And it's kind of on you, right? It's on the patient to say, okay, wait a minute, I'm not feeling well. Let me get a test to make sure I know exactly what this is, and let me get on the phone with my doctor as soon as possible. Or go to the urgent care or something like that to make sure that I get an answer and then have that option available to me. The longer people wait, the higher the probability of a bad outcome. So you really have to be proactive, and I think that's the message now is, we're not doing like mass testing in the community anymore, right? We're not. It's kind of just part of anything else. Somebody gets sick, you got to get a test, and you got to figure out what's going on, and so I really, really encourage people to do that. If they have any symptoms, get a test so you know what you have. And if you have COVID, talk to your doctor as soon as possible to see about getting that medication. The new variants, we had more tools available to us before. So the new variants are not susceptible to monoclonal antibody, which was one of our kind of key treatments.
Not at all.
None. Can't use it anymore. So the most recent version, we've had 3 or 4 different versions we've used. Bebtelovimab is the most current. In the new variants, so BA.5 was the one that was kind of the predominant strain for about 3-4 months. And there's kind of subvariants of that, which are the BQ. So there's BQ1 and BQ1.1, which are about 70% of strains now. And that's here in this region of the United States. And bebtelovimab does not work against those. So we have stopped. The hospital no longer provides monoclonal antibodies. It's not effective. And there's also a medication we used to give, Evusheld, which was a prophylaxis. So people that were really severely, at risk, people with, transplants or getting cancer treatment, things like that, we could give them prophylaxis with antibodies. That is no longer effective. So we're getting limited in terms of the types of tools we have, and so it's more important, it's more incumbent upon individuals to really kind of take that responsibility and not only protect themselves, but the people around them that might also be susceptible.
Yeah, and so that's contrary to human nature. We get something, we feel like, well, I'll see if it goes away in maybe 2 or 3. But that's the danger. You can't. As soon as you have a symptom, you should get the test.
Yeah, I think all of us, right? And I'm guilty of that too, right? I would, you get a little sore throat, get a little sniffle, and it's like I can still go to work. It's fine. But we have to kind of combat that mentality, and make sure we're going to. I mean, the rapid tests are all over the place. You can get them at the drugstore. I mean, a lot of people have stockpiles of them when the government was giving them out for free. I mean, I got a whole box full at my house, right? I mean, like they're all over the place. Yeah. So to get tested is not hard. So I think it's really important that people just do it, even at the first sign, because if you are sick and you do have COVID, and you may say, look, I'm fine. It's not going to, but it's really the other people around you and the ability you have to spread that to somebody that could get ill. I mean, somebody could die because you spread COVID to them, right? And who wants to be responsible for that, right? I don't want to be responsible for that. So it really does, I think, it's incumbent upon each one of us, I think, to take a new level of responsibility that we haven't really had to have before.
Yeah, makes sense. Feel bad? Get tested. And if you've got it, there's the treatment, and it's easy to get.
It's so easy to get.
We
Yeah,
had
so easy to
limits
get.
on how much,
Yeah.
but not
Yeah,
anymore.
that's all gone. Pharmacies have it. All the doctors in the community are familiar with prescribing it. I mean, it's really not hard to get.
Okay. Can pharmacists actually prescribe it?
So technically they can. Yeah, technically they can. The only reason, and no knock against pharmacists, I mean, they're very important partners. If you're somebody that is eligible for it, that means you probably have some other type of medical condition, and you may take other medications, and it has the risk of kind of interacting with other medications. You want to make sure your regular doctor kind of knows what's going on, because there may be medications they need to hold, like maybe you take a blood thinner and you need to be on, they need to hold the blood thinner for 5 days while you take the medication, that sort of thing. So that's why I think going to a PCP is really important, but you don't have to. Yeah, technically pharmacists are able to get it to you even if you don't have a primary doc.
All right, well, you mentioned flu, and if you look at the map of the United States, the CDC shows where flu is prevalent. Michigan is one of those few states where it's not.
Yeah, we're sort of lagging, which is interesting. But those maps also are a little bit late, and I think that within the next week or two, we're going to be orange or red like everybody else. I mean, at least anecdotally, I've even seen. I have friends with kids have the flu. I have it's just it's pretty clear that there's a lot of flu. It seems to be influenza A. There's flu A and flu B, but the strain that is circulating the most this year seems to be influenza A. The vaccine this year was fairly good. It was about 50% effective at preventing flu. But same thing with flu. There's a medication that we have that we can prescribe for people that are at higher risk of progression. And same thing, if you don't know what you have, you can't get the medication, right? So you got to get tested.
What is it? Tamiflu?
Tamiflu.
Okay.
Yeah, Tamiflu. And so same thing. If people have, if they're older, they have cardiac, heart or lung problems, or maybe they're pregnant, right? I mean, you really want to you really want to know so that you can be treated. Kids too. I mean, kids that might have asthma or other medical, you want to try to treat them if you can.
RSV, flu, COVID, they all share some commonality in symptoms.
Yeah.
I would imagine, obviously another reason to get tested to find out exactly what you have.
Yeah, RSV tends to predominate a little more in kids. And so we've seen that across the state for the last few weeks, that the pediatric hospitals have been very busy, very full with RSV cases. But yeah, they all kind of share. You can't tell. It's early on. I think people tried to distinguish. Well, this is COVID or this is flu or this is based on symptoms. But there's no way to know. I mean, there's really not. You can't have somebody come in and say, well, it's a sore throat, it's strep throat versus. And I still see this sometimes. I still see people might go to an urgent care and they get a rapid strep swab and it's negative and they get sent out, with symptomatic treatment. Yeah, you can't do that. I mean, you have to test people for everything else, right? If you're gonna do that, if it's a sore throat, it could be strep throat, or it could be that somebody has the flu, or it could be COVID, or it could be RSV, and that's kind of the first symptom. So a lot of those things, once people get congested and they get some drainage and they start to, they cough or they get some soreness in their throat or they get a little achy, and you don't know what it is until you have to test for it. You just have to test for it.
And each person reacts to the virus differently. So someone might have a hacking cough that just won't stop.
Yeah.
And someone else might just have sore throat and lost their sense of taste.
Totally. Yeah, exactly. And the loss of taste and smell is actually much less common now than it used to be, which is a good thing because that drove people crazy. It's really weird to, not be able to taste your coffee, right? And it has taken, that can take a year before it comes back. But that's a less common symptom now, and it actually makes it harder to distinguish because before you could say, oh, I lost my smell, this is COVID. And that's not really as prevalent now with the newer variants. And we're going to start to see. We should expect to see more variants over time. They're going to keep. It's an unstable virus. An RNA virus compared to a DNA virus When they replicate, they just make mistakes. And so those mistakes, those mutations, happen enough because there's billions of these things replicating all over the world that you get random errors that create mutations sometimes that make it easier to transmit virus. And so that's how we've selected for these things. They keep making it easier and easier and easier to spread. You always end up with the virus that's easier to spread. And that's what we've seen. They keep getting easier and easier to share.
I think we're confused as to what's happening in China right now. When you look back to the start of the pandemic,
Yeah.
the cases started in China and ended up here. What's happening now in China, the population is rebelling against severe lockdowns.
Yeah.
It's not working.
It's
Something's
not
not working.
Yeah, it's not working. Yeah. I think it's hard. It's hard to know what's going on in China unless you're probably in China. And even if you're in China, it's still probably hard to know what's going on in some places in China. But yeah, I think that it's so easy to spread those zero COVID tolerance policies have been difficult to really adhere to. The good thing about what China has done is they made testing abundantly available. I mean, you can get tests out on every street corner, basically. Mm-hmm. So I think that's been a good thing because then it does help sort of control these big outbreaks. But yeah, it's I mean, probably not realistic for all of us to live in lockdown for the rest of our lives.
No. Well, we appreciate all your
Sure.
expertise, and thanks again for sharing with our audience.
Yeah, thank you.
Merry Christmas.
Yeah, Merry Christmas to you.
The Vice President of Population Health at Henry Ford Jackson Hospital, Dr. Courtland Keteyian. Well, if